My name is Andrew Iwa, and I am Board Chair of the Glaucoma Research Foundation and the Executive Director of the Glaucoma Center of San Francisco. It is my distinct privilege to welcome you to the annual Weston Family Lecture. This lecture celebrates the extraordinary contributions of leading clinicians and scientists whose pioneering research continues to advance our understanding of glaucoma. Glaucoma affects around 3 million Americans and nearly 80 million people globally. As the leading cause of irreversible blindness, it emphasizes the critical importance of the work we support and celebrate today. The Glaucoma Research Foundation's mission is to cure glaucoma and restore vision through innovative research. This transformative work is made possible only through the generous philanthropic support we receive from our community. To each of you who contributes to this vital cause, we extend our deepest gratitude. Your investments bring us measurably closer to a world without glaucoma. Today's virtual event stands as a testament to the remarkable generosity of the Weston family, whose unwavering support has made this lecture series possible year after year. Their commitment provides us an invaluable platform to showcase groundbreaking advancements in glaucoma research while honoring a partnership built on shared purpose and enduring friendship. This lecture series holds special meaning, having been established by Gladys and George Weston as a living memorial to their beloved son Danny, who tragically lost his life to a brain tumor in 1998. Though we deeply miss George and Gladys, their legacy continues through their daughter Jane, who remains steadfast in her commitment to this lecture series. She carries forward not only her parents' memory, but their passionate dedication to our mission of restoring vision. The Weston family's enduring partnership represents more than philanthropy. It embodies our shared vision of a future free from glaucoma. For this unwavering commitment, we are profoundly grateful. It is now my honor to introduce Dr. Jane Weston, who will share some words with us as we begin today's program.
Thank you for your kind introduction, Dr. Iwa. It's my pleasure to welcome you to the 2025 Weston Family Lectureship, an event that was very meaningful for my parents, George and Gladys Weston, who established this lectureship in 2007. As the years have gone by, I have carried on their tradition, and the more I get to know about the Glaucoma Research Foundation, the more this family lectureship has become deeply meaningful to me as well. My father, George, was diagnosed with low-tension glaucoma in his early 60s. He was fortunate to be under the care of a superb glaucoma specialist, Dr. Andrew Iwa, who successfully preserved his vision. In appreciation of the care my father received, my parents created this lectureship to provide the public with insights into cutting-edge glaucoma research. The lectures that preceded the COVID-19 pandemic were both educational and social events. I have fond memories of my mother warmly welcoming each guest and my father's more formal introductory remarks. They looked forward to each year's lecture, inviting friends and anyone whose life had been touched by similar challenges. In this post-COVID era, the lecture is now accessible to audiences around the world, something that would have made my parents very happy. Year after year, the Glaucoma Research Foundation selects a speaker whose research has advanced our understanding of this all too common and potentially devastating disease. It is my pleasure now to welcome you to this annual event. I'm so glad you are here with me, and I trust that you will enjoy today's lecture as much as I will. Welcome.
Thank you, Jane, for your continued friendship and for sharing our vision of a world free from glaucoma. My name is Tom Bruner, and I'm the president and CEO of Glaucoma Research Foundation. Our partnership with the Weston family began nearly 20 years ago, and we are profoundly grateful for their collaboration and generous support through the years. We cherish the memory of George and Gladys Weston and are deeply touched by Jane's dedication to honoring her parents and her brother Danny through the annual Weston Family Lecture. This wonderful tradition truly reflects the enduring impact of the Weston family's legacy. It is my great privilege to introduce our dear friend and this year's Weston Family Lecturer, Dr. Carla Siegfried. Dr. Siegfried is a distinguished leader in glaucoma care and research and a long-standing supporter of the Glaucoma Research Foundation. She currently holds the Jacqueline E. and Dr. Alan E. Coker Distinguished Professorship of Ophthalmology and Visual Sciences at Washington University in St. Louis, where she also serves as Vice Chair for Diversity, Equity, and Professionalism. After completing her glaucoma fellowship at Northwestern University, Dr. Siegfried joined the Washington University faculty in 1994, building a remarkable career in scholarship, teaching, and patient care. Over the past 2 decades, she has led residency and fellowship programs, mentored countless trainees, and published extensively in both basic science and clinical research. Our collaboration with Dr. Siegfried dates to her Schaefer Grant Award in 2016, followed by additional recognition of her outstanding contributions to glaucoma research. We've witnessed firsthand her unwavering commitment to advancing vision science, supporting young investigators, and improving care for patients worldwide. It is with great pride and deep appreciation that I welcome Dr. Carla Siegfried to deliver today's Weston Family Lecture.
Thank you, Tom. I really appreciate that kind introduction, and it is such an honor to provide the Weston Lecture for 2025. What a lovely tradition of this family to support this lectureship. So thank you. So without further ado, let's move on to my presentation today. And I always like to start with an outline to give you some idea about how we are going to approach this very complex topic of racial disparities of glaucoma and why it really matters. So first of all, we're going to go through some of the racial disparities of glaucoma and what that really means for our patients. And then we have to go through some of the important challenges and opportunities, including how do we differentiate race? How do we stratify? And what is the concept of precision medicine as it applies? We're going to go through some genetic studies, learn about polygenic risk scores, look at diversity in clinical trials or lack thereof, and some of the impacts of other factors of social determinants of health. Learning about community engagement and public health strategies and how they can impact these disparities. Some of my research looks at understanding some cellular mechanisms of racial disparities and ultimately, hopefully, achieving some targeted therapies for different individuals. So let's move along. Social justice. When we think about taking care of patients, ethics is really at the core foundation of everything that we do as physicians. So we need to think about all of the ethical principles of patient care. Autonomy, which is really wrapped around informed consent, truth, confidentiality, and our patients' rights to make decisions. Beneficence refers to acting always in the best interests of our patients, promoting well-being, and non-maleficence is the opposite, to do no harm. As we think about justice and fair distribution of health resources, we must also understand that it is important to address systemic issues of socioeconomic barriers in order to provide equitable treatment for all. And we must always advocate for such vulnerable populations. So what are health disparities? Well, health and healthcare disparities refer to differences in health between two groups. And this can be a variety of aspects of disparities that can stem from broader social and economic inequities as well. Health outcome disparities, that is what happens because of these disparities, can reflect on life expectancy differentials, mortality, overall health status, and prevalence of certain health conditions. The impact of health insurance coverage cannot be underestimated as well. Is it affordable, and who has access to and use of this health care? There are many factors of disparities. We're going to focus on race and ethnicity today, but that also leads to understanding of socioeconomic status, as we will discuss. Age, geography, language, gender, citizenship status, and sexual identity and orientation can also have impacts on disparities of health and healthcare. As we look at the three major age-related eye diseases, macular degeneration, cataract, and glaucoma, it is only glaucoma that identifies a significant racial disparity throughout the lifetime model here. So we see even in patients who are in their 40s, there is a significantly increased level of Black patients who develop glaucoma. And you can see that that disparity goes on throughout life and actually increases as we get older. So, what do we understand about African Americans and glaucoma? We know that the prevalence of glaucoma in individuals of African descent is 6 times the level of Caucasians, 16 times more likely to result in blindness, diagnosed earlier and with more rapid progression. High eye pressure, ocular hypertension, occurs earlier with a higher conversion rate to glaucoma. African Americans also have thinner corneas, the front window of the eye, and thin cornea is an independent risk factor for the development of glaucoma. We also know that individuals of African descent have a higher risk of developing visual field loss with higher levels of eye pressure. They are diagnosed at a younger age, as in the Hispanic and Latino group as well. In a 20-year follow-up of ocular hypertension, which was the Ocular Hypertension Treatment Study, a landmark clinical trial, showed that there was an increased incidence of glaucoma throughout that 20 years. In addition, as noted, patients who are Black present with more severe disease, and that even follows adjustment for socioeconomic status. So there's something more here than socioeconomic status. There's something more here than also just being from the African continent. There are differences between East African, as shown in the TIMA Eye survey, which took place in Ghana in West Africa, and is the source of many of the African population in not only the Caribbean, but also in North America. Very different from those of East Africa, which have a much lower prevalence of glaucoma. But now for the elephant in the room. What is race? Well, we all think of race as being based on physical traits with a shared ancestry. However, we know that it truly is now a social construct to which individuals can self-identify. So we look at people and we may think that they are looking a certain way and therefore they are of a certain race. But this is different than ethnicity, which is a shared culture. And as we attempt to categorize and stratify individuals to determine some of this risk, it is important that we really understand that that self-identification is a different story than what's really going on in terms of genetics. And we're going to get into that here. I also want to mention categorization and terminology. In the scientific literature today, Black and white is the terminology that is utilized, not European or Caucasian. You will see some of it mixed into this lecture because some of the literature is old and other terms were utilized. So there are many challenges for research of racial disparities. Human studies are messy. There's no suitable animal model. Unlike the time I was giving a lecture and someone suggested that we could use Black mice and white mice. Limited ocular tissue from patients with glaucoma is a definite issue, and racial stratification, racial identification, as I mentioned, People may report that they are attuned to a certain race, but in fact, that may be based on their skin color. And stratification is non-binary, and actual genetic ancestry may be inconsistent. And we'll see some examples of this. So how can we improve racial stratification? Since we know that there are many disparities, well, first we can talk about genetic assessments. And genetic assessments are in terms of DNA. And we know that DNA, think of it as the instruction manual or a blueprint for everything that our body does. And it's like a book with genes that are sentences in the book. So microarray genotyping is a technique where we can identify, like in Ancestry.com, which some of you may be familiar with, these ancestry informative markers, which are single nucleotide polymorphisms. And think of a SNP, as they're called, as a single letter change in your DNA code. And that letter change may have a significant implication on your characteristics. And so you can identify individuals as being in certain groups based on these SNPs. So this is a small study that we did looking at, in our area in St. Louis, Missouri, how these ancestry informative markers were effective in identifying who was white and who was Black. And you can see there in self-report are the red dots, and the purple is the those individuals who were self-reported as white. And most fell into these categories that were consistent with the ancestry informative markers. But as you can see, there's some that are scattered out through the middle here. And some of them self-reported as Black, some were self-reported as white, and they carried some characteristics of ancestry informative markers from both groups. So this can cause a problem as we're trying to identify the genetic basis of some specific diseases and conditions. So we turn to mitochondria. And mitochondria are known as the cellular, think of them as the cellular power plant. So all of our cells need energy to function. And it's from the mitochondria that the energy comes from. And these are tiny organs within the cell that we call organelles. And every cell has mitochondria. But not only do they produce energy, but they also produce, as I call them, the bad guys, the reactive oxygen species, the free radicals, which can act like rust in our cells and cause problems in our cells. And not only do they generate it, but they also scavenge it. So they also take it away. In addition, mitochondria, in their role of cellular suicide or apoptosis, they can also impact glaucoma. And we know that glaucoma can be affected by problems with mitochondria, both in the cells in the front of the eye that control eye pressure, but also the optic nerve itself. So if we think about the mitochondria, they have their own DNA, and it's a very small, short novel of DNA, a very small book. And it follows maternal inheritance, which is your mother's 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 mother. So it goes all the way back, and you can follow this all the way thousands of years to Africa. And if you look at how we all emigrated from Africa hundreds of thousands of years ago, we can identify different groups of types of mitochondria. And these are called haplogroups. And all of us can analyze our cells and determine where our mitochondria came from. And those are from African descent, have the L type. I happen to be European. I did analyze my mitochondria, and I am Eastern European from way back when. And all of these haplogroups can influence severity and penetrance of disease. And haplogroups of mitochondria can also serve as a stratification of individuals. So we have ancestry informative markers and mitochondrial haplogroups that we can use above that of self-report to give a more accurate analysis of where one comes from. So as we think about genetics and precision medicine, we can think about studies called genome-wide association studies, and think of this like a genetic treasure hunt. So we're trying to compare the DNA across a population to identify which changes in those sentences, in those words of DNA, are linked to a specific disease or trait. And in fact, in glaucoma, we currently have, at last count, 127 unique risk loci. So these are unique variants for glaucoma. We don't understand all of them. We don't understand all of these changes in the sentence structure. But we do know that this only explains about 5 to 10% of cases. And unfortunately, most GWAS studies up until the last 5 or 6 years or so have been in patients or in populations rather, of European and Asian descent. And only 2% reflect African ancestry. So that's really a problem, that we don't have a diverse GWAS, but we're getting there. In addition, genetics within a cell can be very different from a whole genome. That is what we're looking at in the entire cellular population in our body. So I'm happy to report we are achieving greater diversity in our genetic analyses, and this will really help us to determine more important findings in genetic analysis. So in cancer genetics, we are far ahead of where we are in glaucoma. You can go have your DNA tested, identify many different risks for hereditary cancers, undergo genetic counseling, be provided targeted therapy, important screening guidance, and this is all a very interdisciplinary field. When I dream at night about what we can do for glaucoma, I think someday we will have a genetic glaucoma risk assessment, and we will be able to incorporate known risk factors like eye pressure, corneal thickness, changes in the optic nerve, and we'll be able to identify targeted screening, family history analysis. But this does require diversity of genome-wide association studies. And it's multifactorial. We'll need to learn about health behaviors and even pollution exposures, et cetera. But we will get there someday, and someday we will have targeted therapies for specific individuals. And I think that the polygenic risk score will be a big factor, where we analyze our DNA, be it from blood or a cheek swab, and this is where we can identify those slight changes in the sentence structure of our DNA to get a more powerful risk score to determine whether it's low, medium, or high risk, recommending monitoring frequency for screening, and predicting severity and progression of disease. We will get there, and we're now looking at validating some polygenic risk scores through several studies. And this is what it can look like, and that we can identify the risk. So if you're in the low group here, you may not need to be screened very frequently at all. But if you're in the high risk, in the 90th percentile, you will need to be followed much more closely. And in that way, we can utilize our resources much more effectively and efficiently. As we look at glaucoma clinical trials, we must further incorporate a diverse group of individuals when we are recruiting for studies. And in fact, if you look over the years here, from 1994 till just recently, we really have not done a very good job of incorporating those at higher risk, the Black, Hispanic, Latinos, into our trials. We're getting a little bit better out here. But even at the very beginning, in 1994, when we looked at that ocular hypertension treatment study and followed patients for 20 years, that was really the first time that there was a purposeful recruitment of Black patients into a study. And it made it much more impactful. This is a look at clinical trials over the last 20 years. And these are trials that led to FDA approval of certain drugs. And if you look at the 31 trials that were used to developed these 13 drugs, we did a really poor job in recruiting a broad distribution of trial participants in terms of race and ethnicity, in terms of sex. And if we look at the first decade versus the second decade, we did get better. More Asians and Hispanic Latino patients for macular degeneration, for diabetic retinopathy, and even for glaucoma. However, the continued overrepresentation of white participants is predicted to worsen in future glaucoma, in future clinical trials. So we really need to be very pointed about how we recruit and how we retain patients. This is an example of something that the NIH has sponsored, which is targeting 1 million subjects to develop a very diverse database to perform a whole variety of studies on many different health conditions, including glaucoma. And currently, there are thousands of researchers who are beginning to look at this data from around the world. And it holds lots of different type of data. And this All of Us research program, this was a study that was published just last year, and looking at risk factors for conversion from glaucoma suspect to glaucoma. So here's a whole variety, and African American race is up at the top, but also age and male sex is associated with an increased risk of glaucoma suspect to glaucoma in this study. More reasons for delayed healthcare access can also have an impact. The IRIS registry data that is sponsored by the American Academy of Ophthalmology, that's been around now for over 10 years, actually has data on 24% of the US population with millions of patient visits, and provides significant research opportunities for us. This is a study from the IRIS registry, also published last year, and shows that Black and Hispanic patients have a higher risk of progression, poor vision, more likely to undergo glaucoma surgery, and are less likely to have eye exams and testing. So these disparities that we can also include in the social determinants of health, of healthcare access and quality, neighborhoods that we live in a social and community context, with impact as well of economic stability, as well as education access and quality. All of this can affect our health and our health care, with lower quality of care in Black patients versus their white counterparts, even if we adjust for income, insurance status, and education. Inconsistent follow-up, lower rates of ancillary testing relative to risk, less access to care and medications, as well as lower health literacy. So all of this data tells us that there are lower rates of care in non-Hispanic Black and Hispanic adults. Public insurance coverage, Medicaid, decreased follow-ups, less frequent glaucoma testing, which is most profound in Black and Hispanic patients. So we can see over and over again these factors of disparities that we need to address. And as we try to understand this, there's even variable response rates in a database, in the All of Us data, this large database of up to 1 million patients to be recruited, that there are a high response rate in terms of overall health, income, but people don't answer the questions when it comes to healthcare access, housing, social isolation, and food security. Why do you think that there is a low response rate to some of these studies and some of these questions? And there's an association of lower income and education level with our odds of seeing an eye doctor in the past year, and higher odds of self-reported difficulty affording medications. What can we do? Community engagement and public health action is really what we need. And I think that this is one example of a wonderful process that we can begin to think about for our patients. And this was a CDC project sponsored through the University of Michigan, and our colleagues in the Detroit area, looking at high-risk, medically underserved communities. And the key is that these individuals were in the community. They were community clinic administrators, people that were on the ground in the community that were friends with the community. In addition, there was a concordance of race and ethnicity between the patient and their provider. So when you have Black patients, to have a Black provider can have a tremendous impact on healthcare and recruitment and retention of eligible participants. And this is how we really need to do it, to embed individuals in the community, to retain them within our healthcare system and our clinical trials. So I want to shift a bit to some cellular mechanisms, basic physiology that I believe is very important, that must be seen in context with all of these other social determinants of health and other factors that I've just reviewed. So for the past nearly 20 years now, I've been bringing the laboratory to the operating room and measuring oxygen levels within the eye of my patients who are undergoing cataract and or glaucoma surgery. And this little probe is actually placed in the eye to measure real-time oxygen levels at different locations in the eye. And we know that oxygen in the eye is not from blood vessels, just like other structures in our body, but actually it's an avascular source because it comes across the cornea. It diffuses from the air and forms a very stable gradient that is highest at the cornea and lowest around the lens. And it's a very low level of oxygen around the lens and in the natural drain of the eye, where that special structure, the trabecular meshwork, is involved in the flow of fluid and the circulation and evaluation of intraocular pressure. It determines our pressure. So we found in our analysis, and when you get a bunch of data, you dice it and slice it in all different ways. And we said, what if we look at racial differences, self-reported? And we were shocked to find racial differences in oxygen levels, and that there were high levels of oxygen, much higher at every location in the African American group of patients versus the white population. We were shocked, and this is we now have over 300 patients in this study. And we had no idea that we would see this. And this is the curiosity of science. And this is the curiosity that the Glaucoma Research Foundation is so set on in terms of grants like the Schaefer grant that I received for our research that fed from this study. So we thought that this might be an important physiologic difference, that maybe the metabolism of the tissues are different. And was it decreased consumption? Is that why there's extra oxygen around? And we had no idea. There's some studies in the exercise physiology literature about a measurement called VO2 max. Was it a genetic basis? We had no idea. So we wanted to explore further. And so we wanted to look at the cells in the drain of the eye that need to have this lower oxygen level, we thought, to function well. So we took specimens from a procedure called trabeculectomy and took some of this material from patients who were undergoing surgery. And yet this contained a lot of different cells. You can get a little corneal cells, a little scleral cells, you can get even iris in here. And most of these patients had advanced disease. So we then identified a new technique utilizing a procedure that's been around for a long time in our young glaucoma patients, but now we're performing this in adults at all stages of glaucoma severity. And it's called a goniotomy procedure. And with this procedure, we can get very precise samples of trabecular meshwork that we can then study. And with this, we have identified differences in how those mitochondria, that powerhouse of the cell, how it functions may be different in our Black versus white patients. And genes that are expressed in these cells may also be different as well, giving us a clue to some of the racial disparities of glaucoma on a cellular basis. And in fact, there are now some studies that are looking at how we can address treatment of mitochondrial dysfunction. And one is vitamin B3, nicotinamide, which has been found to have lower levels in patients who have glaucoma. And in a mouse model of glaucoma, if you supplement their diet with nicotinamide or vitamin B3, that this can be neuroprotective, that it can protect their optic nerve from high levels of eye pressure. Now, we need a lot more research, and we do have a preliminary study looking at this in humans, but believe it or not, we now have a current clinical trial that is ongoing, based at Columbia University and Stanford University, looking at a prospective trial where people are randomized to receive placebo, a sugar pill, versus nicotinamide, vitamin B3, and pyruvate, which is another metabolic agent. And patients are recruited who have mild to moderate glaucoma and looking at changes in the visual field or changes in the optic nerve, not eye pressure. And I want to stress this with all clinical trials that you learn about. It is so important to let the clinical trial show the facts, to analyze the data carefully, and to understand if that treatment is effective, and very importantly, if that treatment is safe. So in fact, because these were relatively high levels of vitamin B3, which you would think would be safe, not everything is safe. And so there have been reports of liver toxicity. So for all of you who are watching this, please don't go out and start taking high doses of nicotinamide vitamin B3. It's important to let the science figure out what's really effective. So I hope today that I have shown you what those health and healthcare disparities are, what those important differences are in access to care and social determinants of health, and how we're just starting to learn about some of the basic cellular differences based on race and genetics, and how we can really expand our knowledge in this category, and why it is so important to study health disparities, to uphold the ethical principle of social justice and equitable care for all, and to support these innovative approaches of studying the mechanisms of disease. Because if we understand why disease occurs, then we can develop more targeted therapies and identify the causes and effects, both from a socioeconomic standpoint as well as a biological standpoint. And this is very important as we learn to develop effective interventions and therapies to improve our health and healthcare and to mitigate disparities for all. In addition, this will help us to manage economic costs of lost productivity of our patients with glaucoma and improve their care. So I thank you for your attention. I just want to introduce the team that I have, an amazing team that I've worked with for over 20 years. Yingbo Shui and Ying Liu, shown here outside the operating room. Hongli Wu at the University of North Texas Eye Institute, who is my redox specialist. Phil Rizicki, who's here at Washington University, and Andrew Wong, who's been a wonderful mentor. Speaking of mentors, all of us in research and clinical care really have amazing mentors in our lifetime. And David Beebe, shown here in the laboratory with Yingbo and I many years ago, was really my biggest inspiration as a basic scientist, and really helped me to understand how to approach a study, and really the exciting enthusiasm that he had for everything that we did. I can't do any of this without the support of incredible people and incredible foundations like the Glaucoma Research Foundation. We also were lucky to receive a grant from Bright Focus and have been very fortunate to receive federal funding as well from the National Eye Institute. I add serendipity in there too. Serendipity helps all of us in the world of science. So I thank you all very much for your attention, and I look forward to questions.
Thank you, Carla. What a fascinating and insightful presentation. Before we begin the Q&A, I'd like to take a moment to introduce Glaucoma Research Foundation's new Chief Scientific Officer, Dr. Cynthia Steele, who will be joining me for today's discussion about Dr. Siegfried's research. We've received a number of great questions from our audience, and I'd like to start with one about is narrow angle glaucoma more prevalent among African Americans with Native American ancestry?
So that's a great question. And I will always acknowledge when I know a general answer to a question and a specific answer to a question. So I am not privy to the precise prevalence of this condition among the population that you describe of narrow angle glaucoma in African Americans who have a background, did you say, of Native American as well?
Yeah.
The question. Yeah. So definitely there is an increased incidence of angle closure in the Asian population. And I would note that angle closure glaucoma has a higher risk of vision loss than open angle glaucoma, especially around the world. And narrow angle glaucoma, angle closure is often diagnosed later, even here in the United States. It is more common in the Native American population, but as far as mixing the two populations, I am not certain of that answer.
So another question that came in was about treatment and the treatment maintenance protocols. How do they differ among patients of various racial and ethnic backgrounds?
So I want to take a step back first to screening protocols, and want to mention family history, and then I'll get into treatment protocols. So family history is very critical. And those individuals who have a first-degree relative, a mother, a brother, a sister, father, son, who have glaucoma, are at much higher risk, up to 10 times increased risk. So that is really a major focus of screening protocols, is to understand family history. What you mentioned in terms of follow-up and treatment protocols really is quite dependent on the severity of the disease and what those treatments are. So, follow-up may be anywhere from every few months to once a year, depending on the status. I also want to mention that in terms of studying family history, not everybody is aware of this. And this is really something we need to get out there in terms of public health and public awareness. And this is truly a problem. And it's not just based on one's socioeconomic status. I have several patients that I follow here at the university who are on our faculty who were unaware of the increased risk of glaucoma that runs in families, and they presented with very severe disease, and it had nothing to do with their access to health care or their socioeconomic status. It was purely based on genetics.
Well, we're approaching the holiday season, and one of the things that we really try to encourage families is to share that information about glaucoma. And I can tell you a story about happened to be African-American college student who discovered when she went for her physical to go to college that she had glaucoma. And when she talked to her parents about it, she said, "Oh, yes, your grandmother was blind from glaucoma. And in fact, your father or someone else in the family also had glaucoma, but it had never been discussed. So here was someone who was really potentially at risk and so we try to encourage families to talk about the glaucoma, to let family members know that your aunt was blind from glaucoma or certain relatives had glaucoma. So I think your point is very well taken that if you don't know it's in your family and you don't feel at risk for it, you may not take the appropriate steps. And if you know it's in your family, and if you know members have even gone blind from it, then that's all the more reason to get your eyes screened at an early age to see an eye doctor and let the eye doctor know too that there's glaucoma in your family. But that brings up another good question is at what age should glaucoma screening begin, especially for these high risk populations like people of African descent? And then the follow on to that question was also, does the age differ by race? So for example, for a Northern European or a white, would you recommend a different time? So could you tell us what you recommend?
So I do recommend starting much earlier in patients who have a family history and who are African American. We know that glaucoma does begin at an earlier age. And so screening should occur probably by the age of 30 in those individuals who are at higher risk. Now, that changes for those who developed glaucoma at even an earlier age. But whereas we would say, at least 40, 50 or so for patients who are white, I definitely move that to an earlier age and even have a baseline screening exam when just as they enter adulthood.
Yeah. I know, Cynthia, do you have any questions you'd like to ask Carla?
Oh, of course. Carla, first of all, wonderful presentation. Thank you so much for sharing that information with us. Your research is just absolutely fascinating and very timely. So we appreciate your lecture. So let's go back to when we're talking about racial disparities in terms of clinical trials. And the question is the problem that Black patients are not being recruited at a higher rate, or is it possible that they're just not interested in participating? What do you think?
That's a great question, and I think it's a bit of both. I think now, over the past decade or so, we have definitely focused recruitment on groups that have a higher risk and may respond differently to therapies. I think we're aware of that now, but it is it is more difficult to recruit patients based on certain cultural ideas about the healthcare system. And I'm making a generalization here because we have in our study where we are measuring oxygen levels are now obtaining tissue from patients. Of course, we obtain informed consent from this process. There is not significant increased risk beyond the surgery itself. However, I feel that when they're my patient, I have that special relationship with them. And I can say that 0 have refused to participate in this study. On the other hand, when you're talking about a clinical trial, which requires time, it is sometimes very difficult for certain populations to participate in a trial, to come for the follow-ups, especially if transportation is an issue, time off work is an issue. So we definitely have challenges with that. But I do think it's both. I do think that it's improved quite a bit in terms of desiring recruitment. If you look at the study with nicotinamide, there was absolutely a focus on making sure that the recruitment reflected at least what our population looks like in terms of racial differences.
I think that's so important because, historically, like, for example, the Tuskegee study, we know that there are reasons why certain patients might be very concerned about going to see a doctor. But I think that's what makes glaucoma specialists very unique. You develop relationships with your patients. This is a lifelong struggle, and you're in the battle together. So Yeah, that makes your perspective very unique. On that same line, what would you say to an African American patient with a glaucoma diagnosis? Like, how can they ensure that they're getting the right care from their doctor?
So I think I am a strong believer in patients understanding everything that they can about their condition. And I tell them this isn't like taking your car into the shop and you just say, fix it, doctor. So, because this is a lifelong condition and that we work together, we don't have a cure yet. So, we need to work with them and identify what treatments are best for them to have a very honest interaction. If they cannot take their eye drops for whatever reason, they can't remember, they can't physically squeeze the bottle, they can't afford the medication, whatever it is, I sort of try to develop a pact with them to say, please tell me when this is an issue, and we will find another way to either get the medications to you or find another treatment that is best for you. And not all our treatments are effective, and this is a lifelong process, and we need to stay together for this. And having been in practice now over 30 years, I have some of those few who I've taken care of for those 30 years.
And do they keep their promise to you?
They do, because
All right.
I don't scold them. I always tell them this is an open relationship. I will tell them when I think that we're losing ground, and they need to tell me when they're having trouble getting along with the treatment. So I think honesty is really the core of my relationships with patients.
I'm going to take one more question and I'm going to pass it back to Tom because this one's very closely related. For those patients of yours who are having trouble with access, and there's obviously economic disparities and insurance coverage and everything that really gets in the way of being able to access even generic timolol and latanoprost. How do you advise those patients, or how do you help them with accessibility to medications or surgeries?
So I do not give out samples because samples are dangerous because when they run out of the sample and we don't have the samples, that's not what they're for. So you can work with pharmaceutical companies if there are economic barriers, and they will provide medications for patients. They have wonderful patient assistance programs that I help guide them through. But sometimes medications aren't the answer. And it has to be sort of a lifelong commitment, and we can take it in steps. And if they can't access the medications, then we move on. Medications are not always first-line therapy. We have other interventions now that may be more appropriate for patients for the long run.
So that does bring up the question of, are there particular types of glaucoma that may be more prevalent among particular ethnicities or racial groups?
So yes, and I had mentioned about angle closure glaucoma. Many of our studies on angle closure, primary angle closure disease, are based in Asia. Of course, we have many Asian Americans who also have that form of glaucoma. But in terms of the most common form of glaucoma in the United States across all ethnicities, it is primary open angle glaucoma. Other specific causes like pseudoexfoliation, which is a form of a secondary open angle glaucoma, absolutely genetically based, and we do have certain populations here in the US. There are certain pockets where it is much more common. For example, in the northern Midwest, where there are many people from Scandinavian descent, it is the most common form of glaucoma that we see in certain areas.
Pigmentary glaucoma, you said.
No, pseudoexfoliation.
I'm sorry, pseudoexfoliation.
Yes, pseudoexfoliation. Pigmentary we see in our young males more commonly than females. The female population who develops pigmentary are a little bit older. Those who are nearsighted are also at higher risk.
So I guess One thing I wanted to mention again, and perhaps you can reinforce, is this whole issue with vitamin B3. And I know the AAO has also spoken about that because it is a widely available vitamin. And it is, I think you made the caution, and I just think it's so important that whatever you're taking as a patient, to talk with your doctor about it, right? Make sure you let your doctor know what supplements you're taking or other things you're doing to try to alleviate or treat your disease, if you will, or to assist, because there are these complications and have been some serious issues with overdose of vitamin B3, I believe.
Correct. People want to grasp on something that may help, especially in a condition that doesn't have a cure. And, some people think that anything that they do that they can take that will help is a good thing. And sometimes it's not, or it's too much of a good thing.
Yeah. The other question I had for you is, and as a researcher, what are you seeing now? I mean, you talked a lot about the polygenic risk score, which I think is a very important development. And I don't know. I know Janie Wiggs at Mass Eye and Ear, and they are actually actively doing polygenic risk scoring for glaucoma patients and doing the patient counseling. Are you doing that at Washington University yet?
We are not doing that yet. It's not really widely available. The cost can be an issue, although the cost of genetic assessments has dropped significantly over the
Right.
last decade or two. But no, we are not just yet doing that. But I do think it has tremendous potential, and it will change not only identifying those that are high risk, which is very, very important, but
Right.
identifying those that are at low risk.
Right.
That will help as we think about our limited resources. There's only so many of us, and there's only so much to go around, and we won't be testing people that really don't need it.
Well, and I think as someone we often hear this from someone who's newly diagnosed with glaucoma, that it's a very stressful experience. I mean, am I going to go blind, right? And if you could do a simple test, a cheek swab, and get your full genome and find out that you're in the lowest percentile, you could probably relax because you'll probably never get glaucoma. So anyway, great talk. Thank you so much for sharing your thoughts with us. And I just want to say that it was very informative, and thank you for taking the time to answer all our questions. We're very grateful for your unwavering commitment to improving the lives of people affected by glaucoma. Visit our website, www.glaucoma.org, for more information about glaucoma and our research programs on vision restoration. Glaucoma Research Foundation is dedicated to advancing innovative solutions, funding groundbreaking research, and supporting initiatives that move us closer to a future free from glaucoma. We know that only through continuous investment in research can we discover new treatments and ultimately find a cure. We're profoundly grateful to our generous donors who share and believe in our mission. Your continued support not only fuels groundbreaking research, but also accelerates the development of new treatment options for people living with glaucoma. It powers our patient education programs, ensuring that vital information and resources reach those who need them most. This powerful partnership between our dedicated researchers and our incredible supporters is the driving force behind every advancement we make. Every gift, no matter the size, moves us closer and faster to more effective treatments and ultimately a cure. Together, we are creating a future free from glaucoma. Thank you for being an essential part of this journey, and we look forward to seeing you next time.